One second here. Hello, everyone. We thank you for joining the seminar today. We have as our guest Dr. Timothy Dillingham and Dr. Mike Kebaetse. Let me introduce them. The way the panel will run today is we'll first have the speaker present. Each will present their approximately 20 minutes or so, given the time that we're running a bit behind, so we apologize. And then we'll take Q&A after. If you have any burning questions, please drop them in the chat so that we are able to respond to them as we move forward. So let me go ahead and discuss the panelists that we have today. So we have Dr. Timothy Dillingham, and Dr. Dillingham is the chair of the Department of Physical Medicine Rehabilitation. He is also the founder of iFit Prosthetics. Tim, I'm looking for your bio. So Dr. Dillingham attended the University of Washington in Seattle, Washington, where he earned his medical degree in 1986. He completed his internship at the residency in rehabilitation medicine in 1988. He is now the chair of physical medicine rehabilitation, and Dr. Dillingham is the founder and CEO of iFit Prosthetics. This is the first company to commercialize a line of adjustable and immediate fit prosthetics. He pioneered the concept of subischial transfemoral adjustable sockets and supracondylar transtibial sockets. Without further ado, I'll let Dr. Dillingham begin. And since Dr. Kebaetse is running behind, once Dr. Dillingham finishes, I'll introduce Dr. Kebaetse so you can put the name to the face. Go ahead, Dr. Dillingham. You can share your screen and begin.
Can everybody see my slides?
Yes, we're able to go ahead and see your slides.
And you can hear me okay?
Yes, we can. Thank you.
All right. Well, I'm delighted to be here, and I'll try and keep us on time. I can be kind of flexible with the talk. I'm just honored to be among you leaders in global health. I have had the pleasure of working with Dr. Kebaetse and Dr. Johnson for many years, and was brought to Botswana through the University of Pennsylvania Botswana partnership, where we tested and provided these prosthetics. And I'm going to talk to you now about some of the outcomes and the points that we learned through this experience. Our mission at iFit is to produce technologically advanced, adjustable, and immediate fit prostheses that are comfortable and accessible to people, so to enhance their lives. And we want it to be patient-centric. So as somebody whose limb changes in size, they should be able to adjust it without having to get a new socket. This company was founded in 2010. And through my experience, I realized how standard prosthetic technology was quite outdated in the way that prosthetics were made, sort of one at a time. And so we started this company, and there's been a lot of sales internationally. We have a partner, Advanced Design Concepts Engineering. What's really good about this partner is that these prostheses were built on solid science, clinical testing, refinement, and state-of-the-art engineering. They provided all the engineering support. They've made injection molds, and now they're manufacturing it. And the advantage to having that under one roof is that there's a high level of quality control between the idea, the product, and the produced commodity. Typically, prostheses are made with a cast of the residual limb, and they're built up over this cast, and it's really time-consuming. Even 3D printing, where you send a digital image and you come back with a hard socket, 3D printing makes a hard socket. It doesn't adjust, and it's only as good as the digital image. And as you know, limbs have compressible tissues. Just feel your thigh. it's very hard to judge how much compressibility is are in those soft tissues. Dissatisfaction with standard prosthetics is pretty well documented. In a recent study, 44% of people reported dissatisfaction with their device, poor functioning, and low health-related quality of life. Some of the major problems are skin abrasions. A poorly fitting prosthesis can cause skin abrasions, infections, and it's a huge problem, particularly for people who are diabetic and can't easily heal their skin or fight off infections. Stump discomfort, high cost of maintenance, and damage to clothes were cited. Worldwide, there's a shortage of prosthetists. So patients in many countries, certainly Botswana, sometimes wait years to get a prosthesis. And what happens then? Well, as you can see in this woman, she had a fixed contracture that we had to fit the prosthesis around that contracture because she'd sat for so long. And what I'm going to present to you is I think that the devices we've developed here at Penn Prosthesis in collaboration with iFit and ADC are a good solution to this problem internationally and in the United States to ameliorate disparities. Why are we different? Well, we're manufactured using injection molding. I like to liken it as traditional prosthesis manufacturers like a shoe cobbler making an individual pair of shoes. We're like Nike making many shoes, standard quality, standard sizes, standard uh, uh, standard products. We've tested our products using ISO International Standards testing. It has a CE mark, which is a stamp of excellence in engineering. They're lightweight but high strength materials. We spend a whole lot of time developing materials that are strong yet light and flexible. It can be fit with hand tools, so you don't need a prosthetic facility. And much of the time we're in Botswana or Zambia, we set up in a physical therapy area or some prosthetic room. Prosthetists can be certified to fit them pretty quickly, a couple hours of training. I won't go into it, but we've been funded by the NIH for many years. I do have a conflict since I'm the owner of the company to what I'm telling you. My opinions are my opinions, not those of the NIH. But we have published studies, prospective trials showing that our devices were rated by people as better in comfort, fit, and function. So I'll introduce the transtibial. Now, I don't know if you can hear this. You tell me if you can't hear this. Can you hear the
we cannot.
you cannot. So what I'm gonna do is I'm gonna annotate it. Okay. So this shows the newest prosthetics of iFit. What we've done is developed sizing for our transtibial prosthetics. And we made this new version, which was funded recently off a pediatric grant that is biomechanically, I think, better than our traditional devices. And they come in 3 sizes, small, medium, and large. Most of the world is small, medium, and large, you know. And most people can be fitted with those sizes. We developed those sizes based on a nomogram of limb measures. The cup is adjustable. So this is our newest addition. It makes it so our cups can fit different limb sizes pretty easily. A pull cord system is what we use. It's an internal cord that's low in profile. So what it does is it fits under clothing better and is a little more cosmetically appealing. Here's how you fit somebody. The circumference was 33 centimeters, which fits the current size that we're putting on him. You just click it in. Our suspension system uses a pin, a ratcheting pin attached to a silicone liner that rolls up the leg. What you do is you adjust the cup and tighten it, and he simply pulls the string, and there's a pulley mechanism that runs internal to the socket that closes the bottom. Then he's going to pull the second string, and it closes the top through a 3-to-1 mechanical advantage. And then you do all the other stuff, you put a pylon, you adjust it, he clicks it on, and walks around. And then you can make micro adjustments and alignment changes. You have to lock tight and tighten everything. What you can see here is that we have a cosmetic cover. We developed a foam cover covered with a sock so that it doesn't look like a pipe. We found in Botswana that people really didn't like a pipe and wanted to look as, quote, normal as they could. So we brought that, and it seemed to be very well received in Botswana, our last trip. We have our earlier prostheses that are really have sold very well. They cover all different sizes of people, and they use a buckle system. All of our prostheses can be heat molded, bent a little bit. You can trim this, cut it a little bit, so it's easily fit. Although it's an off the shelf, as some people term it, it can be customized and fit very precisely to the patient that you're working with. You can put additional padding, and this works real well. And this comes in the kit with all the prostheses. The good thing about our device is you can fit any shape limb. You don't have to wait for the limb to get shrunk after surgery or that. You just put it in a prosthesis. In fact, what you find is that if you put someone, and I think it was this person, in our prosthesis, they shrink very quickly because our prosthesis, when you close it, will tend to mold the limb very, very well. Also, we haven't had any skin breakdown in our studies. We had a couple of abrasions that were easily corrected with changing the padding, but that's a huge thing. We don't break down skin because people fit this as they want to and as their comfort dictates. Transfemoral devices. For many years, the quadrilateral and the narrow ML sockets were the gold standard. They came high up over the hip bone into the groin, and they're uncomfortable when you sit. We developed the subischal socket, and we found that when you have an adjustable cup or socket, you didn't need to go clear up over the hip or clear into the groin. So sitting balance and comfort are much better. Here's what a typical device looks like. And these are hard to fabricate for a prosthetist to make a cast and get it exactly right. Here's how you fit this. And you won't be able to hear it, but so I'll narrate it. This is a gentleman, one of our subjects. You measure up and you cut the prosthesis. It's pretty easy. You can cut it with a pair of special shears. And then what you do is you sand it off, so you make sure it's nice and unsanded. You put the closure mechanism on, you click it on, and then you buckle it. And these buckles are quite adjustable. They have about 10 centimeters of excursion. Now, this is an interesting way to align it. And what's good about this, right there, I have a hard time getting it stopped there, but you see that? You can right out of the gate get a pretty good alignment on people. And this works really well. And what it does is it sets the knee and the leg, the pylon, at the proper position underneath the body mass, underneath the hip. So then you just put on your knee unit, and you can see the knee and the pylon. And then you have them walk. And you have to lock tight. We lock tight all our screws so they don't come undone. And then you do a final checkout. And this gentleman found it no pain, nothing. And you can do that in about 2 hours. And you can ship these anywhere. And a prosthetist or a prosthetist technician can work in very distant rural settings in countries to make sure that people get their prosthesis. What we found in Botswana is traveling to an urban center to get a prosthesis, and probably in many countries, is so expensive and so time consuming for someone in a wheelchair or with a missing limb. You need to bring the care out to where they're at. Certainly a van or a mobile clinic, you can drive to a center someplace and fit patients. Again, so better hip range of motion and gait stability. We've had nobody break down their skin with this, and they all report much better sitting comfort. One of our subjects started riding a stationary bike. Good thing is you can fit these with hand tools. You don't need a big prosthetic facility that costs hundreds of thousands of dollars to fit these devices. The good thing is they're designed to go with any component that's commercially available. So a variety of feet that are made. This is the liner that you roll on the person's skin. It has a pin suspension. This clicks into the prosthesis to hold it up. It's an exceedingly durable, and we've found very good mechanism. Our devices can go in the water. We've tested these mechanisms in salt water, and they work very well. They come in a box, so and all the components there. We've sold some to Zambia and Botswana, and we include a foot and that liner. We can buy bulk, and so we can make this a very price-conscious package. Here's one of our pediatric patients. Has bilateral transfemoral limb loss. We fit him. He was in our study. Incidentally, everybody gave permission that I can use their pictures. So Botswana has been terrific for us. We have a great partner in Dr. Kebaetse, who is very committed to this partnership. We've been there now 3 times, and every time we go there, we learn. And I'll give you some of the outcomes that we've studied. We systematically refine the designs based on Botswana experience and based on the feedback from patients. And some of the people in Botswana have been certified. Our first trip, this was my son. He went to help me. We fit 17 patients in 7 days. And here's some of the patients we fit. You can see how our offset puts the pylon right where it needs to be under the center of gravity for the hip. You see it's a subischial prosthesis. This person had a transfemoral or through knee level amputation. Some more people. Here's someone that we fit, and this was up in Maun, I think, in 21. There was no pain. He was comfortable and stable. This is a gentleman who had diabetes, bilateral limb loss, and we managed to get him up and fitted in about 3-4 hours. And then what happens is these are not miracle prosthetics. They have to have physical therapy afterwards to learn how to walk safely, to negotiate stairs and all that. And the people that we work with were excellent partners, and they provided that rehabilitation that you need subsequent to getting a prosthesis. You have to be a prosthetic candidate. You have to be someone with enough balance, cardiovascular reserve, eye-hand coordination. We fitted in people that have diabetic neuropathy, and they're still able to use this buckle system and our closure systems. And so we have a lot of experience. We're good at training people, but they still need that rehabilitation continuum of care. Just other people. From 2021, patients found our standard devices comfortable but bulky and heavy. They didn't fit under clothes very well and wanted it to look better. So fast forward to 2023, we designed the tibial to be lower in profile. It also fit better biomechanically because it was able to be squeezed around the distal end of the residual limb and form to a more conical shape. Still had the padded liner and rigid side pieces. It goes supracondylar over the femoral condyles. So it's very stable and very forgiving design. These are people we fit. And here's what it looks like. This foam cover was very well received. So we provided the foam cover and a pair of socks. so that when your pants were down or your dress was down, you didn't see this and it looked more normal. And that seemed to be well received. This was in Zambia, a young child. With our recent NIH grant, we expanded the range of sizes we could fit to include pediatrics. And then the pediatrics, this design worked so well, we then moved it up to fit some of the adult sizes, and it's been very well received. It's about a half a pound lighter than our earlier generation prosthetics. This was a guy. Now, then we did an outcome study. Dr. Kebaetse and his crew did their outcome study on a 23 sample. So it went in 21 and 23, and we've been in 24 this last year. We're going to follow those patients up, but we fit 16 persons over 7 days, age 37 to 80, all causes, trauma, dysvascular, infections, hippo encounter. 13 of, no, this was not that was in our recent one. 13 of 16, but they had a lot of infections from bug bites and things that didn't heal. 13 of 16 were available. They filled out a prosthetic evaluation questionnaire and they rated it very highly, an average of 4.8 on a 5-point scale for comfort, adjustability, and function. 92% were still using the device at 1 year after fitting. We had 2 component failures, and I was able to send in the mail replacement components to replace those, and it worked well. We've since re-engineered those parts to be very durable. Here was a poster that we presented, and it showed that in Botswana, we were able to easily fit these folks, and 92% were still using it. They were very satisfied with the comfort and functionality. Here was one of the subjects. Dr. Kebaetse is examined him in follow-up. He was a bilateral limb loss person from a traumatic peds versus car accident. This is somebody we fit recently. This was on our last trip. This was a woman we just fit, a young girl, 16, who had a hippo encounter, hadn't walked for 4 years, never got a prosthesis, and we fit her in Maun. And this was a physical therapy shop where we set up tools and just, fit patients. One clinic that Dr. Kebaetse took us to, they didn't have room in the clinic, so we fit a patient out under a tree. We fit him with the transitibial device, and he walked around quite well. This is a sort of a composite of people that we fit during that trip that we made. We tried to keep all of their faces. Some signed releases, some didn't, so we kept their faces out of so you couldn't view it. The advantage to this is, you can set up in a remote clinic and just in 2 or 3 days fit, 10, 15 patients. Once you get a nice rhythm and that to do it. And you can't hear it, but they're sort of pointing out where to go to leave after clinic. I'll move through a little faster since I know we have some time constraints here.
So Mike is here, Tim, just to cut in for a second. I don't know what's the time?
I've probably got another 2 minutes.
Okay.
That's why I'm going through this pretty quick. These are all people we fit. Dr. Kebaetse wanted a montage of our fittings. And again, we just fit people and oh, here's the guy we fit out under a tree. There were cows looking on. I'm reminded of that country and western song, Everything's Better when cows around. This was a gentleman we fit as well. And he walked very well. Notice how sleek and streamlined our newer devices are. Okay, so I'll go through quickly. There's no other company that makes these products. We are definitely the world's leader in it. They're dabbling in it, but it's a patented technology as well. And what this is it extends prosthetists' time, their ability. It allows one prosthetist and their technician to fit a lot of people quickly, getting them up and rehabilitated very quickly. And that's important. The longer you wait to fit somebody, the worse prosthetic use they have. Why is this ideal? Well, with a complete iFit system, we can make it lower in cost than what some of your insurance people are paying in African countries. So hopefully you're excited and you say, well, how do I get these? It's pretty easy. Go to our website. Call me. Call Dr. Kebaetse. You can, and what we'll do is we'll give you a prospectus and a catalog. We'll walk you through how to get certified. We want any prosthetists to be certified. It's important. These are not like super off the shelf. You still have to fit them, align them, make sure patients are comfortable. So you need a skilled prosthetist doing this is ideal. And what it does is it expands greatly the prosthetist's capabilities to fit a lot of patients. Here's like how to size it. It's really simple. Take a measurement of the distal circumference right here, go down to here. What's the limb length right here? What's their weight? Yeah, they're less than 260. Most people are. So that's the prosthesis, a standard wide prosthetic. Same thing here. This is our advanced closure. So that would be a pediatric or a narrow socket. That's how to size it. It's very easy. There we go. And our website has everything prosthetist. If you're interested, go log in. And that's it. Thank you. I kept it to about 25 minutes. Sorry.
Thank you, Tim. I'll go ahead and introduce the second speaker, Dr. Kebaetse. So Dr. Kebaetse is Dr. Dillingham's partner in Botswana. He's a rehabilitation scientist and consultant. He teaches courses in musculoskeletal injuries, muscle physiology, communication in medicine, and ergonomics, and disability assessment, and return to work topics for public health medicine and trainees. His research interests are in musculoskeletal systems, fragility fractures, development of affordable orthopedic prosthesis, and robot-assisted rehabilitation. He's also my partner there as we do rehab robotics as well. So he's a practicing rehabilitation consultant in injury, and he will be able to go ahead and share his screen so he can do the other part of the presentation today. Dr. Kebaetse, you can go ahead and share your screen. Are you speaking? Okay, go ahead. Yeah, we can hear.
Can you see? Can you hear me?
Yes, yes, we can see and hear.
All right, thank you. Hello, everybody. My name is Dr. Kebaetse, as introduced. So basically, I will present the work that led to some of what our team, Professor Dillingham, was talking about, who is an important partner and sponsor for this here in Botswana. So basically, we went into feasibility of using the iFit technology here in Botswana, and that's what I want to talk about, our experience, and I'll take it from there. Let's see. Oops. Okay. So we know that limb loss is a problem because it incapacitates and debilitates. People's lives are altered in a major way because of limb loss. It leads to high morbidity, mortality for some, and disability, especially for lower limb amputations, both affecting the physical and psychological health of patients. There are a lot of people who are living with lower limb amputations globally, and it is estimated that about 1.5 million amputations annually, and most of those for the lower limbs. And most of these people live in low resource regions, about 5 million in Africa, 75% of whom have lower limb amputations. So again, it's, the problem then with that is that most people who are living with lower limb amputations who don't have prosthesis are mostly in low resource countries, including the continent, and of course, including Botswana. We do know that these devices improve quality of life. We also know that rehabilitation services are quite limited for people living with low limb amputations, especially in Sub-Saharan Africa. And the problem is also true for Botswana. Because we lack a robust prosthetic ecosystem. Some of the challenges for that include the fact that it's very costly to acquire a prosthetic device, talking about conventional devices. If you look at for those that are the cost for securing or having the components that are required for making a transtibial device, we had about $4,600. And a recent estimate from the Ministry of Health is that it can be as high for transfemoral, can be as high as $18,000 to $20,000 on the higher end, especially if they use the audible knee joint. The country has only 11 prosthetists and only 6 centers. Most of these are in hospitals with 1 private practitioner. The healthcare insurance in Botswana is called medical aid coverage, and it covers minimally. As for the motor vehicle accident fund, it does cover, of course, for those who are who have accidents. So it's a targeted insurance, obviously. So the problem with this is that the government then bears the bulk of the burden, or the cost of securing the devices and the cost of the care for those living with amputations. But because you know that governments have constrained budgets, that means then that these individuals have suboptimal care and services. Another reason for another challenge is that because of the foregoing reasons, then people wait for several months to several years. And in some cases, we've found those who've fallen through the cracks, waiting for as long as up to 20 years before fitting. So our objective in our collaboration with the University of Pennsylvania through the rehabilitation, the physical medicine rehabilitation department with our team, Dr. Dillingham, were to determine the feasibility of using the iFit technology in Botswana. And basically, we're interested in how easy it is to use it, how much time it takes to fit a patient and all those. So the nature of fitting and how well the patients would accept this as a new technology, because it looks quite different. And it's as a new technology, then you need to see whether there will be an uptake, or how the uptake by patients is going to be. And also we wanted to look at once patients start using these devices, what are the factors that encourage or inhibit the use of the technology. So those were objectives. And then so along with that, because we would be able to ascertain from patients the time it took for them to be fitted, then we'd have an idea as to how long patients are waiting. The reason that why that is important, or we thought was important, is because when you asked hospitals, especially those that are in the public healthcare system, they would give us favorable periods of waiting, whereas patients, when you ask patients, then it tend to be on the longer side, less favorable waiting periods, meaning longer waiting periods. So basically what we did was we were basically leveraging a well-established and fruitful partnership between the Botswana University of Pennsylvania partnership, which is basically a collaboration between the Botswana government, through the Ministry of Health, and the University of Pennsylvania, and as well as the University of Botswana, so that we are bringing different minds and groups together to work on this project. And through that, we got a charitable donation from the University of Pennsylvania and IFIT in terms of the devices, but also because the team covered its own transportation, hotel, and all the costs. So it was actually a lot more than $45,000 when all that is considered. Then it was collaboration also between prosthetists at the major referral hospital, National Hospital, a mission hospital called BLH, a rehabilitation center in Maun. That way, we are kind of covering most of the country, or at least different, the north and the south. So these, the management of these hospitals granted us access, and that allowed us to work with 3 prosthetists from those 3 different places. We fitted 18. Initially, it was 17, and an extra person heard about us later on, and we were able to fit that person. 3 prosthetists worked with Professor Dillingham. And the benefit of this was then that to give the prosthetists a first-hand experience with the technology, how to assess, how to make adjustments, how to fit, how to then see how patients were responding and all that. So that's what happened with the 3 gentlemen working with Professor Dillingham. And then once they were fitted, we provided initial gait training so that both us and the patient could appreciate how the patient was doing. And also it could give us an idea as to whether how much of additional rehabilitation they would need. With this first group, which was fitted in 2021, first of all, those who were not ready then didn't take the devices home, and that was for safety reasons. And they would return for further training. But all of them, we wanted them to continue the prosthetists for follow-ups, just for any device issue, whether it's skin issues, whether it's fitting issues. So we had agreed with the prosthetists at those 3 centers to follow the patients. You've seen these pictures, I believe. So we followed up between 4 to 9 months post-fitting, and patients completed, well, we asked questions, and then patients were able to complete a comfort utility questionnaire. So out of the 18 that were fitted, 13 were available for follow-ups. We went to see them, to meet with them in person and assess to see whether they're having issues. asked questions of these patients. And the 10 questions that are on that form have to do with comfort and utility, rated on a Likert scale from 1 to 5, 1 poor, 5 excellent. Then you add these points, so you're able to get between 10 to 50 points for each patient. So this gives us then the primary outcome for the feasibility study, that is being the patient satisfaction score. Then our findings. These are the towns where patients are coming from, these three. And you find that most patients came from one hospital, the Mission Hospital, and up north, with only 2 coming from Gaborone here. They're about evenly distributed, 8 females, 10 males, about evenly distributed between transtibial, transfemoral, and the etiology, trauma, and then vascular and other issues. The feed intake for those took 8 days. So you can see already that you can feed a lot of patients within a short time. With each feeding taking up to 2 hours. Those who were fitted in a very short time would took about 45 minutes to an hour. So of those of 18 that we fitted, 10 of them had been previously fitted with a conventional device and had waited for that device between 4 to 3 years. Of the 8 who had never been fitted, which is quite a good number there. The waiting was pretty long, as I said, between 2 up to 20 years, with most of them having waited for more than 4 years. So we're seeing here that there is a very high likelihood that patients were waiting for a long time to be fitted in Botswana. So for those who had never never had a prosthesis, when we get the duration of using a prosthesis prior to iFit, then 8 had never used theirs. Those are used for up to a year, were 3, 2 to 5 years, 10 years, 2, and then more than 10 years were 5. I will skim this again. Now, so quite for those who are fitted, most of them were dependent on the device, so they were heavy users, about 9 out of the 10. And now, once we were following up and looking at the iFit socket, where they're still using it, 7 of the 13 were using it most of the time. And then 3 were using other socket, and then 3 no socket at all. So question that was asked was, how long was iFit 1? 2 were occasionally, and then about, and these numbers showing that 4 were wearing for between 1 and 6 months, and then 6 were wearing it for more than 6 months. And despite the fact that some were not using the device a lot, many, I mean, actually all of the 12 people are recommended that they would recommend it to another patient. So then we would be interested in why did you stop using this for those 6 patients? 3 said that it was heavy or bulky. 1 said that the problem was cosmesis, and the cosmesis here had to do with, the desire or the wish to be able to fit. I mean the way it looked, because the pylon is not covered. A distal pressure was an issue for 1, and then 1 had not been followed up because of weight gain. Didn't wait because of that. And for this one, just because the the patient didn't know how to adjust. There were two skin breakdown issues. Again, just because of adjustment issues, or not knowing how to adjust. And then 11 had no problem with skin breakdown. So when you look at this patient satisfaction scale, and you look at all these questions that have to do with comfort and utility, from volume to, to taking on and off, all the way to the right, you see that most patients were having issues. If it's a long distance walking, you would have that. And then the temperature, a bit of that also. And then climbing stairs. And the reason for climbing stairs was because many of them had not practiced how to use the device on stairs. Because at subsequent follow-ups, they were instructed, and that was no longer an issue. Our experience is that the main issue is really with the temperature, but the temperature has to do with the nylon. I mean, the silicone liner that is used. And patients wearing the device all day, during the day. This place is a very warm or hot place, depending on the time of the year. All right, so in summary, overall, patients were happy with the device, the technology, because fitting was quick. The socket fitted snugly and was able to, especially to accommodate volumetric changes that have to do with patients such as diabetic patients, patients with heart failure. The device felt very stable and working was comfortable. For those who are not happy, the few that are not happy is because they felt that the exposed pylon was unappealing, to look at, and also because one person wanted to wear his skinny jeans with the transfemoral. He was not able to get the jeans over the device. Now, we found that we concluded that it was feasible to use the technology for Botswana. And we noticed also that when you looked at the patients to see where they're coming from, those from the north were very, very positive, had no issues with the device. Those from the southern part, the south meaning around the city here, are the ones who are having issues. And so the question we suspect had to do with social cultural orientation, or could be the prosthetist influence, and also in subsequent conversations with patients and prosthetists, we found that patients in the north don't have access to good health for the most part, and to travel to prosthetic centers takes a long time. They work under conditions where there are farmers, there are fishermen, and other jobs, and sometimes they improvise. They don't have devices. So when they have a device that they can wear and fits well, it's comfortable. The idea that a pylon is not covered doesn't even cross their mind, because some of them improvise, even use sticks to cut a piece of wood and put something on top, a cushion, and then they use that for walking. So it also has to do with people who don't have access to health, to good health, or rehab services and devices. When you give them something that works, they are not so much concerned about cosmesis when compared to the sophisticated city citizens, so to speak. So our recommendations to the government and others have been that this technology should be considered as a viable option for people living with amputations in Botswana. So the subsequent work that has been motivated by this, or has come out of this, was to address patients' concerns that work has been completed and is there's a paper that I believe is out now. And also there's ongoing work in our collaboration with Professor Dillingham and IFIT. There's a study that has received approval and has begun. But other aspects of the study would now begin because we're waiting for trying to get the light this side. All right, thanks. Sorry about that. So in this study, we are exploring prosthetists' views about new technology. We know that when new technology is introduced in a new market, those who've been using old technology are not always readily accepting of new technology, especially if it affects the bottom line in business. So we want to explore these views to see to what degree they may influence patients' choice or decision to use iFit technology. We want to be also able to characterize patients that are most likely to benefit from iFit. We know that it's not for everybody, but it's for most patients. Sometimes when surgeons cut the limb and you have a stump that is very short or a stump of certain size, sometimes they may not be thinking about prosthetic fitting. So those who have very short stump, for example, or not, those who have very weak limbs, patients who are older and have bilateral amputations also may not do that well. And we have some of those examples already in our patient, in our samples, in our sample. And also, we want to be able to recommend to providers and policymakers the best care or guidelines for the best care that can be given to people living with amputations. So the ongoing study, one of the objectives would use stakeholder focus groups to be able to answer that question regarding how we may advise providers and policymakers. And I believe that, and then of course, it's a multidisciplinary research effort. I believe that's it for me. Thank you.
Thank you very much, Dr. Kebaetse. There were, I know we're running a little bit over time. There were 3 questions. We'll just take those 3 questions that were placed in the Q&A, and then we will dismiss the seminar. Let me ask these questions of you guys. So someone asked, thank you so much for a wonderful presentation. This is an excellent development. Are you able to let us know the prices?
Course. The price in the United States for the transtibial is $1,500. The price for the transfemoral is $1,900. Now, if you wanted an African package, another $600 gives you a foot, a liner, and cosmetic cover and socks. So it's about, $1,800, $2,000 for transtibial, and then for transfemoral, you have to throw in a knee joint, which is a couple $100. So for the knees or for the transfemoral, it's probably $2,700. So that's still lower than, according to Dr. Kebaetse and some of our colleagues in Zambia, it's lower than what other companies provide. The other advantage to that is that that you have to have multiple supply chains to get knees, pylons, clamps, sockets, epoxy, goops, all those kind of things that you have to when you create your own prosthetic. And so those supply chains, some of the components are very expensive. Oser and Autobach have good products, but they're expensive when they're brought to under-resourced countries. So we sort of get, and the advantage to that is that I know everything fits together well. It works well. it's durable, it's tough, it's gonna be a quality product.
Thank you, Dr. Dillingham. The other question was asked. Thanks a million for the high impact work that you're doing, doctor and team. Do you also provide upper limb prostheses for children?
No, we do not. And it's something that I keep thinking I should write another STTR grant and see if we can do, because I'm asked about it a lot. The issue is that the incidence of upper limb loss is about 1/100th the incidence of lower limb loss. So there's not a huge market, but I think that there is a need, and that's certainly something we're thinking about.
There was another question asking for you guys to maybe support a program in Zimbabwe. Any chances that we can get your assistance for a prosthetic program in Zimbabwe? I'm starting on a study. This is from author. May put your name, author. Maybe you can put your email in the chat so we can get that to Dr. Dillingham and Dr. Kebaetse. They're starting on a study in biomedical engineering and very interested in seeing people get rehabilitated in Zimbabwe too.
Would Mike, do you want to take that?
Of course, that's feasible. What you can do is share emails, exchange emails, so that we can discuss it further by email and phone. Adam, Michelle, have you provided the contacts?
So we can provide your contact in the mail, or you could just drop it in the mail right now. And I just put in the mail author, the question from author, and author, if you're still on, if you can drop your email in the chat, then Dr. Kebaetse could follow up with you directly. That'd be great. There's another question. Well, just a thank you from Eric Sanchez. Thank you for being here, Eric. And then there is another question. Thanks, doctor. I will be happy to contribute to the grant application. We have a young person. We have a young one in our family who needs prosthesis. She is the inspiration behind our business, Bionics for Africa Healthcare. I think that so there is someone, I guess, who would be willing to collaborate or join a collaboration with you guys. I think that was what's that about.
Dr. Kebaetse is our leader for Africa, and with his wide experience and travels, we've been, we love to partner with people. I think that to really get this out, what has become clear to me is that you have to build capacity and interest and a way to make prosthetists make a living. The insurance company benefits from a lower price. And so that all aligned in that workflow, it's successful. And it won't be successful if it's not. And so I think the most important things is what Dr. Kebaetse has done is he's contacted the major insurers, the people who can benefit the country, and then the prosthetists, the people who would be fitting it, they need to make a living. So I think when you build a structure and a foundation like that, you have a much higher probability of a long-term success. Or you get one of your rich benefactors in one of these countries to start a foundation and buy prosthesis for everybody.
Well, thank you so much for the presentation. We're about 8 minutes over, and to be conscientious of people's time, I want to just thank again Dr. Timothy Dillingham and Dr. Makutlo Kebaetse for their time, for a wonderful talk about the possibilities in terms of immediate fit prosthesis for low resource settings. If anyone have any follow-up questions, Dr. Kebaetse put his contact in the chat. So so I will actually stick that in there.
Mine. Been
Yes, we
Yeah.
can put yours as well, Tim, in the chat so that anyone can reach and touch base with you. You can go ahead and put that in the chat. Thanks again, everyone, for listening. We'll start up again in January, the third weekend. Happy holidays for those of you who are going on holidays for this time period. Merry Christmas if you celebrate Christmas. Happy Kwanzaa, Happy Hanukkah, all these other holidays that might be coming up around this time. And thank you for another great year in terms of presentation. Take care.
Thank you for your leadership,
Thank
Michelle.
you.
Thank you. You're welcome. Take care, everyone.
Bye-bye. Happy holidays.
Happy holidays, everybody.